Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, I would like to express my sincere gratitude for Dr. Mohsen Baqali for inviting me to share this presentation in your meeting. I was asked by Dr. Mohsen to speak about presbyopia, lens-based solutions, not cornea-based solutions. I believe Professor Ali will be covering the topic of the cornea. So, my main presentation today is about the famous multifocal intraocular lenses and the new generation of trifocal intraocular lenses. And I think, in my opinion, the big barrier or hiccup in the road of implanting multifocal intraocular lenses is the psychological barrier that we have in our minds. Because we think and we believe that sometimes these patients, because they are paying more, they expect more, and if they do not get what they expect, then this can lead to potentially troubles with our patients. So my presentation today is mainly aimed at how to avoid unhappy patients after implanting trifocal lenses, mainly trifocal lenses. So, I believe that there are factors for success in any patient who is going to undergo a trifocal intraocular lens. It's very, very important to do a good patient selection. You have to do preoperative measurements very accurately. There's a big issue in IOL power calculation in these specific subgroups of patients. The surgical technique, and the patient has to have a healthy anterior and posterior segment. If you take one thing at a time, looking at the patient selection, now these are things that this is not complicated. These are things that we used to look at differently when you're doing cataract surgery and implanting monofocal intraocular lenses. So it's like a paradigm shift that we have to change in our minds and in the way that we speak to our patients. Of course, we should consider the age, the functional occupational requirements, the degree of general alertness and ocular pathology, and the patient visual demands and expectations. But there's been classically taught that patients who insist on not wanting spectacles, these are dangerous patients that you should avoid when you're selecting your patients for multifocal intraocular lenses. But the thing is, with the trifocal intraocular lens generation, these subgroup of patients actually are good candidates. The thing is, you have to explain and you have to thoroughly emphasize what are the expectations after the surgery. In other words, if the patient insists on not wearing spectacles at all, we should not punish this patient by giving him the worst solution, which is a monofocal intraocular lens. So he will be needing glasses for far, he will be needing glasses for near, and maybe he will be needing glasses for intermediate distance if he is like working on a computer most of the time. So in these patients, we should not punish them by giving them this worst solution, but instead we should explain to them that in the current status quo of medicine, of ophthalmology, we cannot give them 100% of their needs. He or she cannot be spectacle independent forever. But what we can offer is like 80% of his needs. So if he implants a trifocal intraocular lenses, he most probably will be spectacle independent for far, for intermediate, and he will need just very weak reading glasses for near. If the patient is approached this way, then these patients that insist on not wanting spectacles at all can be tamed and can understand that this option is not there and can accept the results of trifocal intraocular lenses. So suggested patients are patients motivated to reduce dependency on glasses. Presbyopic patients with or without cataracts. I'm not a strong believer in refractive lens exchange, But again, I always want my patient to have a touch of cataract for me to justify the procedure that I'm going to perform. Hyperopic patients, of course, are easier to please as compared to myopic patients. Bilateral implantation candidates. This is very important. We should not mix and match trifocal intraocular lenses with any other monofocal or bifocal intraocular lens in the other eye. Actually, what we do tell the patients that the full power and the full advantage of the trifocal intraocular lens will never be reached unless he implants them in both eyes. So the effect, the optical effect that you will have from one eye has to be matched with the same optical effect in the other eye to get the maximum benefit. And again, these patients should not do the both procedures in the right eye and the left eye months apart. I select the patients that are ready to have the second eye operated as soon as possible. So what are the absolute exclusion criteria? Unrealistic expectations. If the patient insists that he does not want to wear spectacles at all and refuses that he will be given 70 to 80% of his requirements. Or patients who are happy wearing glasses, who actually tells you that I like my looks with the glasses and I don't plan on taking them off. If the patient has a pre-existing ocular pathology, age-related macular degeneration, corneal disease, or anything of the sort, and anticipated high post-operative astigmatic results. Again, I will show a case at the end of this presentation that shows that the trifocal intraocular lenses are a little bit more forgiving for astigmatic patients than multifocal intraocular lenses or bifocal intraocular lenses. But again, classic teaching is if you have a patient, you anticipate that you will have more than 1.5 diopters of corneal astigmatism. If you're going to treat this patient, the astigmatic component, then go ahead. If you're going to implant a toric trifocal intraocular lens, then go ahead. But do not implant a regular trifocal intraocular lens in these patients. What are the relative exclusion criteria before surgery? Patients with more than 1 diopter of preoperative astigmatism, unless ready to cope with laser enhancement. RK, PRK or LASIK patients, we have challenging biometry, and the only problem in these patients with trifocal intraocular lenses is only the biometry surprises. The optical effect of the trifocal intraocular lens does not interfere with the oblate cornea that is a result of previous corneal laser surgery. But the main problem in these patients is challenging biometry. Of course, if you have night working drivers, this is subject to discussion with the patients because classically all multifocal intraocular lenses causes a little bit of night halos, but the new trifocal intraocular lenses, the new generation, they cause much less halos than the old generation. So the new kid on the block, the thing that we really need to consider before offering our patient a trifocal intraocular lens is to measure the angle kappa. Steve Schallhorn reported a result of a large series of multifocal intraocular lenses and the relation of angle kappa, and this took actually the best paper of the session, the Askers, in 2016. And he reported that angle kappa, when it is more than 0.3 millimeters, does affect the results of the multifocal intraocular lens, especially the trifocal intraocular lens. So how much displacement would you accept for trifocal implantation? I would say a 0.3 millimeters, especially in the horizontal axis. The vertical axis does not affect us that much. And again, these are examples of the vertical displacement and horizontal displacement. And in vertical displacement, we really don't care that much, but in horizontal displacement, we do care. Would you recommend a trifocal intraocular lens for a patient that underwent LASIK? Being trifocal, they are more LASIK friendly than classic multifocal intraocular lenses. If the patient has low corneal higher order aberrations, the sole concern is, again, challenging biometry. But the trifocality itself does not interfere with the optical zone of the oblated cornea, and we should use the Barrett 2K or the Haigis L. Exclusion criteria during surgery: significant visual vitreous loss, pupil damage, and zonular damage or capsular excision. So my nomogram or my paradigm in these patients, if you have all the patients presenting for cataract surgery, if they are motivated to be free from spectacles, if they are not motivated to be free from spectacles, then go for the good old monofocal intraocular lenses. If they are motivated to be free from spectacles, even if they are very motivated, you should not punish these patients by giving them the monofocal intraocular lens. So multifocal implants are suitable for 60% of these patients. If they are motivated with realistic expectations, these are the ideal patients. And these are actually 80% of the patients that we see. If they are motivated but with very high unrealistic expectations, and these are challenging patients that you should talk to. But if they have totally unrealistic expectations of ocular pathology, then you go back to monofocal intraocular lens. So what about preoperative assessment in these patients? You have to have an accurate biometry and keratometry measurements for best postoperative results. Perform tomography and not topography, tomography to all patients who are considering trifocal intraocular lenses, and this is mainly to know the corneal astigmatism, the total corneal power, and the angle kappa. We all use interferometry biometry, no one uses ultrasound anymore. Calibrate the instrument to manufacturer's guidelines. Small errors in axial length measurements can cause significant errors with intraocular lens power calculation. Recheck if the difference is greater than 0.3 millimeters between two axial lengths, and self-optimization with the track results of 30 patients. We should tell the patients to discontinue contact lens wear until stable keratometry reading is confirmed. And I usually tell the patients, if they're using soft contact lenses, most of the patients now are using soft contact lenses, not hard, to stop them for at least 1 week. Assess the ocular surface and manage OSD before performing the preoperative workup. And this is very important. Actually, one of the very main causes of dissatisfaction of the patients after implantation of trifocal intraocular lenses is the presence of ocular surface disease. The thing that we have to change in our minds when preparing this patient for cataract is that we target emmetropia or a little bit of hypermetropia, which is something that we were never trained to do. We always aim for a bit of myopia, and this is something that you should not do if you are implanting a trifocal intraocular lens. As regards to the IOL power calculation formulae, we should use new generation formulae, for example, SRKT, Barrett. One should carefully choose the formula and consider using different formulas depending upon the patient individual measurements. And of course, if you can personalize your A constant, this will come very handy. What's the best formula to calculate trifocal intraocular lens power? Which third generation formula gives the best results? Will ray tracing or artificial intelligence related formulae like the Olsen or the Hill RBF formula will be more accurate in trifocal calculation? Myself, I use the Barrett formula, which is actually free and online. But will the artificial intelligence formulae be much more accurate? Only time will tell. Do you need to use the Hoffer Q in hyperopic eyes like we do in monofocal intraocular lenses? This again is a good question, but again, the Barrett formula fills most of the gaps for these patients. The keys for success: proper patient selection, careful biometry and power calculation, appropriate surgical techniques, inform the patient preoperatively of glare and halos, and discuss symptoms and their reduction over time. We have to counsel the patient, talk to our patients, tell them that reading is limited in space. There will not be a continuum of vision. You'll not go back to your 20-year-old vision where you can see far objects, intermediate objects, and near objects in a continuity of sharp vision. No, a trifocal intraocular lens is a trifocal intraocular lens. So it'll be focused for far, for a point in the intermediate distance, and for reading. And the distance in between will not be as focused. And this is something that we really need to tell our patients, because when they find that post-operatively, they are very happy and satisfied. When they discover that the trifocal intraocular lens does not give a continuum of a sharp vision, without being told so preoperatively, sometimes the patients are not that much satisfied. Tell the patient before surgery best outcomes is bilateral implantation, and again, this is very important. Vision quality with one lens is not ideal, and patient with only one multifocal lens implantation should be reassured that proceeding with the second implant will improve the visual outcome. So this is a case I would like to present on with the PanOptix, just to show you how forgiving these lenses or this new generation of trifocal intraocular lenses are. This was a 58-year-old male with asteroid hyalosis seeking trifocal intraocular lenses. He was a low hyperope with an astigmatism of 1.5 diopters. And this is his tomography or pentacam. Again, he has a 1.3 diopters of corneal astigmatism on tomography. Okay. This is the video of the operation. I just wanna, I'm not sure if it will work. Okay, that's fine. Now these patients, I prefer putting a capsule tension ring. I used to do this in all multifocal intraocular lenses just to centralize the capsulorhexis and to avoid any small tears that happened in the zonules during the surgery, and to centralize the optics, the complicated optics of these lenses. I stopped doing this now, but this was my standard technique at the time. This was a PanOptix implanted. And again, this patient, as you see, had an astigmatism of 1.5 diopters. I did an opposite clear corneal incision, good old clear corneal incision with the keratome, no fancy stuff, no arcuate incisions, no limbal relaxing incisions, no femto, nothing, just an opposite clear corneal incision in this patient. Immediately post-operative, this was on the second day after the surgery, doing a tomography for this patient, we can see that this patient had less than 0.5 diopters of corneal astigmatism, and his uncorrected distance visual acuity was 0.7, and the near visual acuity was J1. The patient was extremely satisfied. This was a trifocal intraocular lens in a patient who had 1.5 diopters of astigmatism with no fancy treatment for this astigmatism. So I think the most important for consideration trifocal intraocular lenses, I know the alkon staff will be very happy with this slide, because I made this abbreviation with alkon. Okay. So keep the patient's immetrope or slightly hypermetrope, avoid total corneal astigmatism more than 1.5 diopters, avoid angle kappa more than 0.3, not 0.5, and cover your patients with the alkon counseling. What is the alkon? A is for adaptation to a trifocal implant, takes some time. L is that he will need light glasses. C, there will not be a continuity of sharp vision. O, the other eye should be operated as soon as possible. And N, night halos can be present but are neither handicapping nor permanent. So thank you so much. And this is a picture of me and my family at the Royal Palace in Morocco. Again, it is an honor to contribute to this prestigious meeting, and thank you so much for the invitation, Dr. Mohsen Baqqali.